Hello and welcome to the Healthcare Huddle podcast. Today's episode is a little bit different because this is going to be a replay from our Learning from an Infectious Outbreak webinar. And unfortunately, we had a few technical issues. And so I'm having to do a little bit of an intro into the webinar because that actually got cut off during filming. I'm going to be giving an introduction into the independent investigation report that we're discussing here so that you've got a bit of background. I'm Rachel Slauson, the host of the webinar. I'm joined on the webinar with Darren Thorne, the Managing Director of Fassi Emelius, and Fassi Emelius is a healthcare consultancy business that undertakes independent investigations in the NHS, and Geraldine Lavery, who's worked with Darren on a number of projects and also led the editorial board. So there were 13 patient stories and they were collated, and then they went to an editorial board where there was lots of clinical input that reviewed each of the patient stories and their chronologies. And then all of that information was distilled into the overarching report, which is the report that we'll be discussing today. First of all, we'd like to offer our condolences to the families of those involved in this outbreak. In February 2019, Public Health England identified an outbreak of invasive group A streptococcus, or IGAS. It's a bacterial infection. The outbreak affected people in the Mid-Essex area. 39 people were actually infected and 15 of those patients sadly died. Fassi Emelius was commissioned to undertake an independent investigation into the outbreak in line with the NHS Serious Incident Framework. The purpose was to learn from the care provided to the patients who suffered from harm and to support learning and reduce the likelihood of similar events happening again. So the Fassi Emelius team, led by Darren, reviewed over 1,700 documents. These included clinical records, local and national policies, protocols and guidelines. They looked at minutes and notes of organisational meetings and other relevant information from a number of stakeholders that were involved across health and social care. They then spoke to 34 health and social care professionals and invited contributions from the relatives of those who'd sadly died. They reviewed the care and treatment of 13 individuals and identified 43 examples of opportunities to learn. The findings cover 5 clinical areas. These included wound management, clinical deterioration, antibiotic therapy, infection prevention control, and record keeping. And we'll be discussing all of that in the rest of the webinar. And just going back a bit, so Group A streptococcus is something that quite a lot of people might carry on there without any issues, but
it's a bacteria.
It's a bacteria and it lives on the skin, and if it gets into a wound, this is how these things get into the body, and then that's when the problems really start. So okay, and then so how did you go about undertaking this type of investigation?
Well, I mean, it's always a challenge. So just at a very kind of high level, we gathered all the notes. We started to develop chronologies and identifying where there was potential variances of care. We interviewed a number of people. I think there were over 30 people that we spoke to who had delivered the care, both in the community setting. We spoke to some GPs, we spoke to some care homes, we spoke to the hospitals that had provided the care at the end. And then we synthesized all that, and the investigators, so we had several people working to author the individual patient stories, and we established what we have called a clinical editorial board, where we bring together clinical experts that reviewed the initial drafts of the report, validated some of the findings, and I started to identify what were the key issues that we needed to bring forward into the summary report. So at a very high level, that's how we undertook the investigation.
And I think it's important just to say that for the 13 people that died, I mean, these were very sad cases of elderly people that weren't potentially at the end of their life, but through catching this infection, probably hasten them to the end of their life. And the patient stories were very much focused for the family. It was so that the families could understand what had happened to their relative, and they were supported by very detailed chronologies that actually set out all the clinical information. But very much the individual stories were, they were for the families to understand what happened.
And just so clear, though, the individual patient stories weren't shared publicly, were they? They were shared directly with the relatives who you'd engaged early on, and then the overarching report was the report that then was released. Yeah.
And within that, you know, obviously all the themes and the areas that we identified through the patient stories form the basis for the overarching report. And, you know, when people read the report, they can see in there, we gave examples, vignettes of things that had occurred for the treatment of individuals. I mean, all of those were anonymised, but we've been able to use examples throughout the independent report to show where maybe care wasn't as good as it could have been, or where good practice did take place.
Yeah, really, really hard to pull all of that together, because there was so many, each story has so much in it already, and then you've got to try and collate all of that into the themes. So, and so should we move on to the board assurance tool and the recommendations?
Yes, let me talk about the board assurance tool. So we've developed a tool. So I don't have it on a slide, but it does exist, and it can be downloaded from our website. What I would say is that there have been some issues with that download, but that's being resolved today. It's quite a comprehensive document. It's 12 pages long, and what it does is it helps organisations think through what are the assurances that their board needs to seek to assure themselves that, in effect, the things that we found in this investigation aren't happening in their own organisations. So it's a kind of a bit of a challenge to the board themselves to ensure that they get the right information, they're reviewing the right things. And what we'd like to do is to start to take you through some of the recommendations just at a high level, but I really encourage everybody to we'll send out a link after the event to look at the assurance prompts, and they're not just for healthcare, they're for social care as well. So they're aimed at all of the kinds of providers that were involved in our investigation, and commissioners of those organisations. So are relevant to local authorities, clinical commissioning groups, and for providers, care homes, nursing homes, community service providers and hospitals.
Yeah, so there are 22 recommendations in the report, and they've been broken down into different areas. So the first area in the report is wound care, and I know from reading that there were 5 wound care recommendations, and 2 of those relate to non-registered staff undertaking tasks that were outside of their competency level and potentially not adhering to policy. Do you want to discuss the remaining recommendations and maybe comment on how they all came about?
Yeah, so shall I start just by talking about some of the things that we found in wound management, and I'm sure that Geraldine can add some thoughts to these. So I think one of the key things that we found in the wound management was around policy. So there were policies, they weren't necessarily always adhered to, but what we also observed is that actually some of those policies, when you analyze them in terms of exactly what are they asking you to do as a clinician, seemed to be quite ambiguous, and it was unclear whether certain things should or should not happen. So I think that was one of the first areas that we were seeing. So there was inconsistency in clinical practice, potentially that had the environment of the policy had encouraged that inconsistency. And I think that the kind of off the back of that, there was a lack of audit of policies as well. So there weren't robust clinical audits looking at the clinical care that our patients had received in line with the clinical practice that had been determined locally.
And I think that what happened then, that led to inconsistent practice within the community, particularly where you know, the policies weren't, or the guidance wasn't being followed. So if people had wounds, there wasn't always a holistic assessment of that wound care. wounds weren't always monitored properly. So, you know, photographs of wounds weren't taken, measurements weren't taken. So there was a limit then to how effectively they could be monitored about whether there was improvement or not, or a decline in the wound, and also about when escalation needed to happen, either to a specialist or to a more senior person for advice on, you know, if the wound wasn't progressing, then what else should be done. So it was this inconsistent practice that was happening all the time, I think.
I think one of the other areas around wound care was around swabbing, that there were quite often delays when we created the timeline of when the swab was requested. Sometimes it didn't happen, and sometimes it was delayed quite significantly. And given the condition that Geraldine's outlined, these patients deteriorated quite quickly. So actually, maybe a couple of days may not appear on the face of it to be that critical, but when you look at the progression of the disease, when you've got IGAS that's taken hold, actually those hours are critical. And particularly there were some directives from the incident management team that were trying to manage the outbreak. There was a directive that went out that all patients should be swabbed, and we looked at whether that directive had actually been applied in the cases that we looked at, and quite starkly, I think in the majority of cases they hadn't been swabbed.
There was only one where that
30
was followed. Yeah.
So I think that was definitely a significant finding. I think one other area around wound care management was around how the use of healthcare support workers possibly were being pushed or encouraged, or there was a void of maybe qualified people that were wrapping their arms around the healthcare support workers enough that encouraged or enabled people to potentially work outside of the competencies that they'd actually had, or the boundaries that they'd been set.
I think that's right. And it was about, was there proper supervision of practice for untrained staff, for HCAs? And, the evidence of that was very limited to be able to see that. I think the other area was in the acute services, because all of these individuals eventually ended up in hospital, and all I think except for one had a wound. And none of these, these wounds weren't always examined. So, if they had bandages on, they weren't always taken off and the wound examined as a source of infection. So that was that's one of the important recommendations I think we've made to acute services about ensuring that when somebody comes in and sepsis is suspected, that any wound should be examined to see if that's the source of the infection.
Yes, and I think it's just building on that, it's really important for us to highlight that the transmission of IGAS is generally through wounds. And therefore the management of the wounds in this particular context is really important, because they were the source, as Geraldine just said, of the transmission. I think that covers sort of the key areas that are findings in terms of wound management.
And just a question about, so the reason that the acute hospitals didn't take down the dressings, what was was that because they what was that reason? Do we know?
I think we heard that some of the staff weren't trained within the emergency department to be able to undress wounds and redress. And I think that there wasn't the equipment or the bandages and the to be able to redress the wound. They didn't have those facilities within the emergency department. That's my recollection of the problem in the emergency department.
And that's because they're specialist compression bandages that are maybe only used in the community, and to actually put those on, you need specialist.
It wasn't just those that were wearing compressing bandages. It was people that, you know, had a wound dressed, wasn't examined.
Right. Okay. And the next area is identifying clinical deterioration. And there's 4 recommendations in there. And when I was reading it, what was really interesting was that the news, you know, I can't remember the name of, I can't actually right now remember what that acronym stands for, but it's about you managing your clinical deterioration. You get a score, it's a score sheet, isn't it? And you determine how ill a patient is, and it gives you a number at the end. That wasn't used consistently across the community. So there was no benchmark or a standard that everyone wasn't speaking the same language, were they?
Yeah, so I think that so just to help your memory, NEWS stands for National Early Warning Score. No, it's recognised nationally, and I think that one of the things that we identified was that it wasn't consistently applied across the patients that potentially needed it. But actually, one of the other issues here, when we really examined what was happening with NEWS across the healthcare system, was that different parts of the system, different organisations were actually using different versions, so they weren't quite aligned. So therefore, you've got a potential challenge there at handover, because if one organisation is in NEWS 2 and one's using the primary version of NEWS, then they're not there are just some subtle nuances between the 2 versions of the scoring system. So I think one of our recommendations.
Yeah, I think one of the community providers didn't use it at all.
Yes, that was another issue that I was going to come on to. But you're absolutely right. Yeah, it wasn't consistently. So where it was being used, they weren't all using the same version, and that the community provider didn't have a system for early warning deterioration. But what I would say around this, in terms of deterioration, was that we saw some really good examples of timely practice, where some of the hospitals that were using NEWS, and particularly NEWS 2, were identified and were acted upon, and the bundles of antibiotics that were required were given within a timely manner. So the Sepsis Fix tool was implemented, even though it wasn't necessarily beautifully documented that they were implemented, but the clinicians on the team, our experts were able to look at the clinical records and say, actually, although the template or the checklist that had been developed within the organisation hadn't necessarily been used, the patients had received the right treatment and within the hour that was requested. But that wasn't always the case, but there were definitely some good examples. Geraldine, do you want to say something about continuity of care?
Yeah, I think, I mean, one of the things that we identified was that sometimes an individual was seen by a number of different healthcare providers in the community we're talking about here, really. And, you know, even though that in itself isn't, isn't going to say that quality of care isn't going to be good, it does limit the care that somebody has, because you're not getting to know the individual, the trust that gets built between a consistent individual working with the same person, the knowledge, being able to look at somebody and think, well, she's not looking quite well, or she wasn't looking like she was yesterday. So I think there was even though we were not able to sort of really identify how many people looked after every person, there were cases where we could see that there was something like 32 individuals that were involved in one person's care. So there were things about teams and how many people looked after an individual patient, and that continuity of care, and does that affect the quality of care? So there were areas that we identified there. And I think the other thing is just sort of on undertaking basic observations. These weren't routinely undertaken in the community, so that, again, it's just, the softer signs, being able to see that somebody is, not looking quite the same, or today, or maybe slightly under the weather. What does that mean? So I think there were things there that, you know, the holistic look at the individual wasn't always taking place.
I think that just to reiterate, some of these, we're talking very basic vital signs.
Yeah.
Weren't always being taken in the community. So we're talking temperature, we're talking blood pressure. You know, those things weren't consistently taken. You know, those things that as a nurse might say are just innate markers of, you know, how physically they are.
During the investigation, there was a point when equipment taken into the patient's home was limited, wasn't it? So nurses who were attending a person were not able to bring all of their equipment with them, were they? They weren't able to bring, you know, the nursing bag. I don't know, my mom's a district nurse, so I know about the bag, you know, the bag which has got all your gubbins in. I'm sure that there's a nurse on here horrified that I've called it gubbins, but, you know, it's got your stethoscope and it's got your blood pressure and, you know, the thing you stick in your ear for your temperature, you know, all of that. And they limited that, didn't they?
That's a nice segue into the next area of recommendations, which was around infection prevention and control. And you're right that there was a series of directives, pieces of advice around trying to suppress and stop the transmission. And in that, people were being asked to change their PPE practice quite regularly. And I think that one of the things that we identified was, you know, that there was inconsistent messaging. And it was perceived that from the community services seemed to be the group that were being targeted for a lot of the PPE recommendations. At least that's what they perceived. Yet there were other agencies and other professionals that were going into those homes of those people that didn't have the same requirements around some of the PPE expectations. And I think that therein lies another issue, which is around if you have a PPE policy and then you find yourself in an environment which will sound very familiar at the moment, where PPE requirements constantly change, it becomes incredibly difficult to monitor what is today's guidance and how we're monitoring that everybody is actually adhering to that, because it's almost purposeful variation from a baseline policy, and you could end up on sort of variation 10 because actually it was wear that yesterday, and today it's, you know, you need to change what you need to wear, or the type of gloves or the type of protection that you need, and today you're not allowed to use that piece of kit because we're concerned that might be transmitting the virus or the bacteria. So inconsistent messaging and constant change, I think, were significant issues and led to confusion. I think that's reasonable to say, isn't it, Geraldine?
Yeah, I think so. Yes, definitely. There were mixed messages, and the messages weren't always timely. So, you know, we heard from different people about when they were told about infection control and, you know, when they were told to wear equipment or not wear PPE equipment. So, yeah, it was communication was around it, I think, was a big thing.
I think one of the things that really sticks in my mind is that, and it's a really important lesson for now and for any kind of management of outbreak, is around we look back. So we were doing a retrospective investigation, and we were shown letters that were sent out to clinicians that weren't dated. It wasn't clear who they were sent to. So you have a letter that comes out from a central agency saying you need to do X, Y, and Z, but it's not clear who it's been sent to, who's distributed it, on what date. And therefore, for an investigating team, it's really difficult to pinpoint exactly when something happened. And I think that there was one particular case that I recall talking to one of the investigators about, and they were saying that, you know, they had treated one of the patients that was part of our investigation, literally a couple of hours before they received the email with the letter on that told them they needed to do X, Y, and Z. And that's really important when we're doing it, when we're doing those timelines, because minutes and hours matter. Because if we hadn't have got that right, it would have potentially seemed like the GP hadn't implemented the things that everyone else had been asked to do. So I think that's the kind of granularity that you have to go to when you're doing this kind of work.
And it's also not just about the communication being pushed out, it's whether or not was it received, because I know there's certain instances where communication between a council organisation and a hospital trust can't happen because the one system hides the messages because they quarantine it. So it's not just about the communication going out and saying, oh, I sent an email. It's about, was it received? What was the follow-up? Was there a check-in that person actually understood it? What were the action points? It's not just enough to just push a message. It's did they receive it? Did they understand it? Was it, it's a two-way conversation, really.
I think that's important. And I think the other thing that was important was that all those agencies involved weren't all getting the same bits of information at the same time. So, care homes got sort of left out a little bit in the quite a lot, I think, in the communication system. And actually, a number of these people were living in care homes or receiving care at home from a domiciliary care agency, and yet they didn't have the information that the community had. So I think it was important going forward in the future, anything like this is really understanding who are the agencies involved and how do we make sure that they're all communicated to with the relevant information.
And I think that plays into our one of our recommendations about outbreak management plans, a phrase that probably we're all familiar with now. And they're really important so that everybody knows what their role is and what is expected of them and where the handover points are. And where the interdependencies are. I think in and around that, one of the things that we also found and was around the available expertise in the community. So what was really quite different in this particular outbreak is that it was so community based, and having access to experienced IPC teams or staff or competency that had experience of managing outbreaks across a community setting was really challenging. And I think to be fair, the community service provider absolutely acknowledged that. And I think there is a potential national shortage of those skills and expertise, particularly in the community. Sorry, Geraldine, I cut across you. You were going to say something.
Yeah, no, sorry. Or the only other thing I wanted to sort of say was around infection control, was around, again, it was about policy implementation. And, we saw that some of those individuals who are in hospital should have been isolated once IGAS had been identified and yet weren't. So even though the policy indicates that isolation is necessary, it didn't happen, or it was delayed in when it happened. So I think, again, it's all, this brings you back to the guidelines and policies that staff have to work with, and ensuring that there is a way of how do we know that they're being followed and implemented.
And just in case there's anybody non-clinical on here, IPCT stands for Infection Prevention Control Team, is that correct? Okay, yeah. Perfect. I know interestingly, one of the recommendations I actually think sort of applies to me. I was told I was allergic to penicillin, but actually I think I might just be intolerant, and there is a really huge difference. And in the report, there was at least one occasion where it was more than one, wasn't there, where somebody was given an antibiotic they were actually recorded as allergic to, but actually could be like me, where it's actually I'm intolerant. And that for me was really fascinating.
I think there were 7 individuals that were identified of having various at various stages in their clinical record as being allergic to penicillin. And I think, you know, what you're saying is right. There's a confusion between a real allergy, which is very dangerous and, you know, can cause an anaphylactic shock, or an intolerance where maybe somebody has a more low level sort of effect of having penicillin, you know, something like diarrhea or just feeling generally unwell. And it's amazing, you know, there's I can't remember the figures offhand, but it's something, you know, it's quite high, the number of people within the population that have some sort of intolerance to penicillin. But of those 7 that were identified as allergic, 5 of those were given a penicillin-based antibiotic. And in only one case was the drug error, was it recorded as a drug error, because it is a drug error, and whether there was an adverse reaction or not. So I think there's a number of issues around here, and it's about really recording accurately what the individual has to penicillin. Is it an intolerance or is it a true allergy? And also recognizing that if somebody is given a penicillin-based antibiotic when they are termed not to be able to have that is recorded as a drug error, and any adverse reaction is recorded as well.
I think that's really important, and I think one of the things that our microbiologist talked about was that potentially there would be scenarios where a clinician may decide to take the risk, that the benefits of someone being penicillin intolerant against them being given it, you know, that's a clinical judgment, and we completely accept that. And however, it goes back to record keeping around, well, the records show that someone's potentially allergic, then you need to record that in your clinical judgment you're going to give it anyway, because the benefits of receiving that drug outweigh the risks of you potentially having some kind of intolerance. I think it's just building on what Geraldine said, it's about 10% of the population claim to have an allergy to penicillin, and actually that often relates back to childhood skin reactions based on being given penicillin, not necessarily, you know, a full blown allergic anaphylactic reaction to a drug.
And it was important as well because the strain of IGAS was actually penicillin was a good antibiotic for it, whereas the alternative that they had been using to start with wasn't as effective or didn't work at all, and actually in some cases may have made a difference.
I think it was the efficacy of the alternative antibiotic that was given, and whether that was enough to deal with the IGAS infection.
So
and I think just to kind of build on that, I think it's really coming back to the discussion around having a clinical editorial board, you know, having a microbiologist. So let me just sort of diverge shortly for a little while and talk about that a little bit more. So in this particular instance, we had a wound care specialist, we had someone who was a director of nursing but had a district nursing background, we had an infection prevention control specialist who was based in community with community expertise, and we had a microbiologist, and we had a very experienced medic. So the rich conversation that took place around that table around some of these cases was invaluable, and particularly around efficacy of drugs, and, you know, what should be second line if the first line has failed or isn't available because of the clinical environment of the patient. Sorry, digressing there slightly, but an important point.
Just to go back a bit, so the reports were drafted, the individual patient stories were drafted, and then there was an editorial board that went and reviewed in detail all of the information in there, including these really, really massive chronologies. And then from that, the reports were, you know, discussed and lots of clinical input, and then amended slightly, and then the overarching report was built from that. Is that the format?
Absolutely, and let me give you a sort of a picture in your mind around how that happened. It was a fairly intense 2-day affair where people were the authors came in and they talked about their case, and we had access to all of the documents that were available, and this is where our kind of unique numbering system comes into its own, because we were able to every piece of evidence that we receive is stamped with a unique number, which gives it's a sort of the code is segmented into various bits, so we can tell which organization has sent it, you know, who has sent it, which patient it belongs to, and then it's given a sort of unique document number, and then each page has a unique page number as well. So we were able to, where there were conversations, and there were some very interesting conversations, some I recall with the microbiologist saying that couldn't have possibly happened, and we were able to go, okay, let's tap in the code, bring up that piece of paper on the screen and actually examine that record in detail, and it proved to be absolutely invaluable. And actually, the microbiologist was a little bit dumbfounded by some of the things that we heard. And if I may get this slightly wrong, so Geraldine, do correct me if I get any of the detail wrong. But I think it was particularly pertinent in one case where there was a delay in the culture being taken to the lab. Quite a significant delay. I think it was days, wasn't it? I think. To the point that it was reported on, the culture was reported on within a matter of hours, and the microbiologist said that there's no way that you can grow that culture in that time. Of course, the actual key answer here was, well, the culture had been growing for days because it had sat in the potentially wrong environment in the fridge and hadn't been cultured sort of within the lab. So it's things that may seem not possible or not normal that we can understand in the moment of discussing it. Anyway, that's
and so I think that's important in terms of how you go about a big investigate, the foundations of getting that system that is called Bates numbering system, and I think that it's used within courts, and solicitors would be very familiar with it. Getting that in immediately, and every single piece of documentation was logged on a spreadsheet, so we knew what had been received, when it had been received, who had sent it, and then this numbering system assigned. You know, you have to get that foundation in at the beginning, because 1,700 documents later, and goodness knows how many pages, because if anyone's dealt with patient notes, you know, they're not you know, often quite a big beefy volumes. And so I think getting those foundations in first sets you up to be able to have that. Otherwise it would just have been, it would have been really challenging. So the last section is the supplementary observations. Now this is a bit of a collective, isn't it, of...
You've missed report writing out.
Oh, sorry, yes, report.
Well, talking
record keeping.
about records, yes.
Sorry.
And I guess this is a chapter that you could write in pretty much every investigation that we've done. So record keeping wasn't consistent, and you know, some of it's more important than other bits, but you know, there are still professional expectations and standards around completeness, and we've discussed, you know, in some of the environments where it is really important, like the drugs. But yes, we found that the records were variable and suboptimal to the standards that would be expected of medical records. And I think we also found we made some interesting observations about the audits that people do around record keeping. You know, very much about demographics rather than actually the quality of the note that has been made and how reflective it is of the care that was given.
Yeah, and I think it's just to say, you know, and I think you're right. I mean, I'm sure most investigations will pick up something about record keeping, but I just think it's, you know, it's really important because actually it's an integral part of patient care. And it serves as the basis of planning and treatment. And it's also, you know, it's a means of communication between professionals and a formal record of describing what treatment, you know, and care has had. And we all know if it's not written down, it didn't happen. And I just think it's we shouldn't underestimate the importance of good record keeping.
Oh, we have had a question. Thank you, Barbara. She said she's finding it interesting and a nice relaxed format. Well, that's good, because I'm not sure I can do anything other than relax. But so she's saying in Scotland there were many deaths due to C. diff a few years ago in one hospital, which after investigation indicated essentially bad clinical governance. Lessons were learned, but that in this pandemic there is no obvious supervision or gold standard of infection control pathways being followed anywhere. Do you think that the health service will face a tsunami of court cases due to deaths from COVID-19 as a result of inconsistent/inappropriate practices? If so, what should we be doing now? Should we be developing a COVID-19 safe monitors, staff that assess/identify good and bad infection control practices? If the workplace they monitor passes the stringent infection prevention controls, infection prevention controls practices, if they monitor the standards, this would provide some assurance for the staff and patients that their workplace has been risk assessed.
Gosh, that's a long question.
I agree. We need...
Okay, so I think just in sort of brief response to that, I think that I think every organisation needs to be encouraged to review what they did in the first wave. You know, identify where there were things that could change, possibly against the standards that you've cited. I think that would be, you know, it would be inexcusable really to not have gone through that process of learning lessons and sort of self-reflection collectively. Because there were so many areas, and I mean, I'm not being critical of, you know, the care that people have been provided with, but there's always opportunities to learn, and I think that we have. I don't know whether you've seen them, Barbara, or anybody else that's on the webinar, but we have published some webinars or little videos around COVID and some good practice. So, and maybe they're worth encouraging your colleagues to watch some snippets of them to get them into the place of improvement.
Yeah, it's called the Healthcare Huddle on YouTube, or you can follow us on Fascio Melius on LinkedIn and Twitter. And I'm usually putting up little either clips from the bigger videos or, you know, linking you to the video. So yeah, the Healthcare Huddle podcast, we've created some videos, and we have done a whole series around why you should investigate transmission of COVID within a healthcare setting, like from one patient to another, and why that's so important, and then the lessons that you can learn from that. So Darren, it is 10:19. Do you want to just quickly go through the I might be able to find the link for anybody who's interested in the podcast. We'll send it out in the email. I'll send you a link to the podcast. So do you want to cover the supplementary because the board assurance tool that you've done, and my understanding, and let's face it, I was a project manager, so I didn't get involved in this type of situation unless somebody gave you a project to do with it. But it essentially gives you a format through which you can work through the recommendations and check whether your organisation is doing things that give you assurance that you're not going to make the same mistakes. So essentially, I think some of it would say about record keeping. Are we auditing the correct thing? That's what the document includes, doesn't it?
Yes, it does. I mean, let's just talk through what some of our observations were. I mean, we've talked about communication quite a lot around sharing of information, you know, making sure results get to the right place in a sort of timely way. And we did identify across the cohort. And one example is around a phlebotomist that received a request to take a blood sample, but didn't realise that there was a home visit required, and there was no record that the GP was informed about this, and or that the mistake was rectified. And I think it was several days, possibly a week,
5 weeks actually before.
5 weeks before the blood test actually happened, and that may have had a significant factor of delaying identifying the infection. So.
And I think, if I can just say, there was another case where communication was really sort of very poor, and it was where an individual had moved from one GP to another and from one care home to another, and the results of her wound swab were not communicated to her new GP, and nor was the community nursing team aware of the transfer of her to another home. And actually that person went without care for nearly 2 weeks, and was seriously ill by the time she was taken into hospital. And that was about communication and making sure that people just don't drop through the system, that there is proper transfer and handover of care.
Yes, there was another area as well around patient choice, which was quite it was quite difficult to write about in the report, because a patient clearly has choice, and I think it was, if I can recall correctly, around about they didn't particularly like the bandages that the nurses and the healthcare support workers were using. So I think that the standard word of how healthcare professionals describe that scenario tends to be around compliance or non-compliance, and what didn't seem to have happened, there hadn't been a sort of step back, possibly even a kind of a safeguarding conversation, to understand actually this person appeared to be quite capable of deciding that they didn't want to have what was considered to be the most effective care, and how that is then handled.
I think, yeah, and that was important. And there was one particular case, but there were a number of cases where people weren't able to or didn't want to follow the care and the guidance that they were given, or the treatment, or weren't happy with what was being offered, particularly in that case about the bandaging of the wound. But it was about really trying to understand why, and that didn't seem to happen, and to seek alternative advice. If you have got somebody that really can't cope with the recommended wound bandaging, what else can you do? So how else can we help this person, first of all, understand, if they don't, what the outcome of that is, but what are the alternatives? So, and again, I think it's this looking at the person as a whole, and trying to understand what's going on. So, and they are, it's things that I think organisations need to look at. When there's a patient choice and they don't want to follow the recommended choice, what do you need to do?
I think we've got two other areas. One we've already covered, I think, around serious incidents and doc errors, and making sure that they're reported and that patient safety incidents are acted upon. The last observation was around self-administration of medicines. Geraldine, do you want to talk through this scenario?
Yeah, it was just, we had one of the people that ended up in hospital had a piece of equipment where he was being treated for another illness that he had, and had a machine that self-administered medication. When he was taken onto the ward, the staff didn't know how to use this machine, and his partner, his wife, had to come in every morning and every evening to turn the machine on and turn it off. But the staff on the ward should have escalated that to the specialist team to enable support to be given, to take the burden off his partner having to go in and out of hospital all the time. And that didn't seem to happen. And again, it's a recommendation that if people are coming in with different pieces of equipment, that a specialist team, because there would have been a specialist team for this illness that this gentleman had, that could have helped and supported the ward staff and released the burden from his wife.
We have had another question. Leslie asks, there was a brief mention early on, but were there any areas of good or outstanding practice that you identified? When you add these to the report, how do families receive this information, i.e. my relative suffered harm, but there was good practice? Thanks,
yes,
Leslie.
that's a really important point. Thank you, Leslie, and probably a nice point to end on. We do always look for best practice, and we always try and bring it forward, because it's a bit too easy just to focus on, where are the opportunities to learn, and by the nature of that, you're suggesting something was suboptimal or not quite right. We do, and we did identify areas of good practice. We talked about the news score earlier, and there were some cases that we did investigate where actually the report was very positive, that people had the care that they should have had, the treatment that they should have had, in a very timely and caring way. So we do try to bring those forward, and I hope that we give those kinds of examples equal balance in the report, because it's not just about opportunities to learn, it is about highlighting the best practice. I think there wasn't a huge amount of gold standard practice in our review, but I don't know whether Geraldine wants to add some sort of further words to that about that individual case where actually we felt everything was definitely good.
Yeah, I mean, just really to echo what you said, I think it was an elderly lady. She, as we looked through, as the chronology was developed, you could see that things happened appropriately in the right time, and it's just unfortunate, that's not the right word actually, but it was sad that she had this infection and died from it, but we couldn't find anything that wasn't as it should have been in her care. And I think there were other examples of I think it was a HCA alerting the GP when one of the individuals who was a diabetic was demonstrating symptoms, immediately made a call to the GP to check out what she needed to do, blood sugars, that sort of thing. So yeah, there were examples all the way through, and I think we make that clear in our report about saying, yes, generally care was as it should be, but there were areas for learning and important areas that, things didn't happen as maybe they should have done in the most timely manner.
Okay, well, thank you. Thank you for everyone that's asked questions. Rachel, I'm going to hand to you to close and to tell everybody where to look for all the information. And yeah.
Okay. Thank you so much all for joining us and spending time with us here today. And I really, really hope that you learned something. We will be sending you out the slides from this presentation and the board assurance tool, which Geraldine and Darren have been talking about, which you can use in your organisation. We'd love to hear if there's anything else you would like us to cover in future. Make sure you follow us on LinkedIn and Twitter. So it's at Faceremelius, which is FACEREMELIUS, and that will keep you up to date with any of our latest training. We actually have another webinar session on the 6th of November, and that is all around NHS regulation standards. So it's navigating through the landscape of regulations and standards within the NHS in England has been extremely difficult for some time. So it's a bit of an introduction into all of that, and that one's free, and it will be on Eventbrite again. So it'd be great if you could, as you're leaving us, if you could leave us with a one-word checkout of anything. Oh, is the report of your study going to be available for us to have a read through? That's a question I've just had from Rachel.
I think you were going to send a link.
Yeah, let me just kind of take that. We will send a link. It is published on the CCG's website, but we'll send you a link to the publication.
Brilliant. And as you're all checking out, it'd be great if you could just say one word of something that you've learned. Oh, thank you. We're having some very nice compliments.
Oh, great.
I'm going to go with I was enthusiastic. I hope everyone has a really good day and stay safe, everyone. We'll see you next time.
Thank
Bye.
you. Bye-bye.
I really hope that you enjoyed the webinar from today. Make sure that you're following us on LinkedIn and Twitter so you can be kept abreast of all of the latest information that we're sharing and also any other additional training that we're sharing and putting on as webinars. So stay safe and we'll see you next time.